So doctors, let's begin our next session, IC373. And may I please request Dr. R. Unnikrishnan Nair from Trivandrum to take over, please.
Good morning, everybody. And we'll be doing quite an important IC hopefully today, which is we call alphabet lingo, because all the new terminology that has been introduced inside retinal imaging, we'd like to demystify it and decode it a bit for you and reinforce what we said with a small interactive session after that. So I will be doing the first talk in the session, and which will be mainly centered around dry AMD. I'd like to welcome all the co-instructors and speakers before I just start, and we'll be starting the talk now. So what this talk about is the new lingo that we all talk about in retinal imaging. That is, we call it the alphabet soup. So I'll be covering mainly the topics that is associated with dry AMD. And why it needs to be covered is that in the name also has a significant description by which we learn the pathogenetic process and mainly understand the evolution of disease, especially in AMD. So there's only two outcomes in AMD, that is atrophy and scarring. But there's actually only one outcome in AMD, that's atrophy, whether it is direct or secondary to scarring. And the pathway to atrophy can be in the absence or the presence of a CNV. The description of atrophy is two. One is a primary age-related atrophy, and the other is a secondary, not a secondary, a drusen-related atrophy. And macular atrophy has been defined by the color fundus imaging, fundus autofluorescence, and multicolor imaging. And this is a seminal study that is combined the consensus group to define one of the simplest things we think, that is what atrophy, to define it. It is the report number 3, in which the OCT, fundus fluorescence, autofluorescence, and near infrared reflectance and multicolor have been used to define what we understand as atrophy. And the terms have been introduced, which are the CRORA, or the complete RP and autoretinal atrophy, IRORA, incomplete RP and autoretinal atrophy, CORA and IORA. So to define the atrophy, the inclusive criteria of CRORA, complete, is that there should be at least an area of 250 microns of continuous hypertransmission. Hypertransmission occurs because of RP atrophy, and the signal goes down. There should be a zone of attenuation of RP atrophy seen tomographically, and also evidence of overlying photoreceptor degeneration. Any presence of a RIP or a scrolled RP is excluded to define CRORA. So this is some pictures from that seminal article, in which here you can see a continuous zone where the RP and the photoreceptors are lost, and hypertransmission due to that is seen. In an incomplete case, you can see that the areas of the RP is still persistent over there with photoreceptor retainers, and you don't see continuous hypertransmission or transmission of the signal and areas of intermittent normalcy. The interesting thing is that now the term we use of geographic atrophy is only considered a subset of CRORA, by which CRORA is also defined when there is the presence of a exudative membrane. So this is a typical example where you have a pigment epithelial detachment with content. Probably there's a possibility of fibrovascularity over there, but the area of transmission encompasses that, because the RP overlying this particular PED is also atrophic, and it still forms under the terminology of CRORA. So these are some of the examples we have. You can see the hypertransmission, a total loss of tissue overlying that area with the dipping of the vertical loss of stability and dipping of the layers. Here you have another significant larger area with areas where there is even a preservation of ELM in one area, but there's an area where the total photoreceptors have been degenerated. And another example where you can see a very clear cut and loss of the RP, and even in the presence of drusenioid PEDs and PEDs, you can see that if the overlying RP is atrophic, you can have and define CRORA in the presence of that. How about the incomplete atrophy? The incomplete atrophy, as you see here, you see vertical hypertransmission defects, which show that in between areas there is persistence of the RP and the photoreceptor layer, which blocks the signal, and the signal continues downwards in the other areas. This is another example where you see incomplete defects Vertical transmission defects with normal areas intervening. This is interesting because, as I said, even in the presence of elevation, you can see vertical transmission defects, which show that focal areas of RPE loss are present. This particular hyperreflectivity is called a core, which is another feature which has prognostic value in atrophy. The terminology called nascent GA. Nascent GA is a subset of incomplete atrophy that happens in the absence of a CNV. That's very important to know. Here you see small areas, but what defines nascent GA is the dipping of the ONL layer and the INL layer. This is called, and hyporeflectivity here called wedge-shaped hyporeflectivity. This is what defines nascent GA or early phase of incomplete atrophy. So as I said, the subsidence or the dipping of the OPL and the INL layers you see here, and here you see hyperreflective areas which correspond to the dipping, and this forms nascent GA. Another terminology that we need to know is subretinal drusenoid deposits, SDD or pseudodrusen. So any pseudodrusen or subretinal deposit is anything that forms internal to the retinal pigment epithelium, in contrast to what we normally call drusen. So these are well-defined areas located above the RP. There's a 52% association in AMD, but this is like the presence of subretinal drusenoid deposits is like aggressive AMD or AMD on steroids, where there's a 3.4 times increase, or in some cases a 6.1 times increase of reaching advanced AMD characteristics like advanced atrophy or advanced exudation. So these are some of the examples of the triangular deposits that you see above the layer. You can see the deposits above the layer over there. And there's a predominance to be found in female and is highly bilateral. There is a theory for how SDD occurs. That is, there is a defect, two lesion, two compartment. There's a defect in the retinal pigment epithelium lipid recycling pathways that cause deposition above the RP. And also it has been thought that there is a derangement of the choroidal circulation. The choroid capillary forms atrophy and fibrosis, therefore causing a derangement of the RP, causing all of this to happen. So there are dynamic structures. If you look in this picture, first there is only an obliteration of the layers, and subsequently mounds are formed, and then a triangular penetration of the ELM happens in stage 3. A few studies have noted that there is over a 3-year period, the choroidal thickness and the photoreceptors thickness decreases by more than 75%, and the area affected by RPD lesions increases at quite an alarming rate also. So these are some examples of things. Here you can clearly see the penetration of the ELM by the triangular deposits above the RPE. And over time, there is resorption, which leads to an atrophic change. And this is highly prominent and fast in nature. So there is an association of ventricular pseudodrusen with vascular insufficiency and choroidal insufficiency in females and hypertension, which shows it could be not an atrophic lesion, but a vascular insufficiency lesion. So the other thing we'd like to talk about is hyperreflective foci, in which RP cells detach and they move anteriorly in the retina. So these, the RP cells instigate by producing deposits, they damage the brooks. The brooks in a reverse action causes more RP cells, and therefore these detach and move anteriorly. So here you can see the presence of hyperreflective foci on the presence of drusen over there. They can be seen in above a drusenoid PED, as you see in this picture and in this picture. So over time, you can see these anterior, they call anterior migrating RP cells. However, there is also an alternative pathway for RP destruction. That is, instead of moving anteriorly, they move into the as a laminate deposit sideways, and this causes pseudo-vitelliform type of lesion with sloughing into the subretinal space, forms the anterior migration of HRF. So this is a patient with nearly a 10-year follow-up, and as you can see, this has a pseudo-vitelliform lesion. Over years, there are changes that happen, and over years you can see the atrophic changes increase. The pseudo-vitelliform material is resorbed, and finally it ends up in a severe and significant atrophic change. So we have two types of HRF: the anterior migrating, that is the atrophic pathology, and a posterior migrating, that it starts in the retina in vascular pathologies and they move towards the RP. We are here talking about anterior migrating RP cells or hyperreflective spots in atrophic AMD. An interesting thing we see is also called drusen ooze, which is characterized by two significant features. First, the presence of a hyperreflective foci or overlying the drusen, and second, isoreflective, which is equivalent to the drusen content coming through these defects in the RP above the drusen. And this phenomenon has been called drusen ooze. It's very nice to see some of the similar pictures initially showing hyperreflective dots on the top with some isoreflective dots inside, and then a giveaway of the RP with the isoreflective material coming outside, like oozing out of the drusen. So here are some of the pictures you see where you can see a clear deficit or an aperture in the RP with material coming outside, drusen ooze. Also a significant indicator of atrophic AMD. Here are some pictures in which you can see content coming out of the drusen. Wonderfully, here you can see a large gape in the drusen top with material outside. A beautiful thing is outer retinal tubulations, which is a very commonly a degenerating photoreceptors trying to protect themselves, huddling together, and it is a common final pathway in many, many diseases. And it happens in the outer nuclear layer, and happens when there is significant outer retinal architecture loss with a relative preservation of the photoreceptors which try to save themselves. So here you can see the presence of outer retinal tubulations or circular arrays of photoreceptors overlying a scar. And here you can see isolated ones with thickened borders, again over a scar. And this is an on-fast view, and it has a scrolled up appearance as you see over there. Okay. So ORTs based on cross-section can be closed, open, and forming or branching. The closed ORTs are stable, and they usually are take about 12 to 14 months, and they are called stable if they are present for at least 3 years. So the ORTs are an attempt for the photoreceptors in the failure of an RP to protect themselves where the RP is dysmorphic. The ELM is an important structure which causes the formation of the tubulations by touching the base layer first and rolling up the photoreceptors inside them. There are 4 types in which they're flat, where the ELM just separates, J-shape when the tip touches the RP, and then it starts curving back on itself. This is a 3D construction of the ELM that is rolling and scrolling and containing the cells. So the on-fast shows 2 images. There's a pseudodendritic pattern when it forms over a fibrovascular scar, and then there's a circular pattern with the like invaginations from the edge when it is at the junction of normal and atrophic retina as in GA. So when you see ORT, you can know that ORT is has been seen in the presence of previous subretinal fluid, or it is at the junction of intact, that is preserved, and damaged retina. Finally, the choroidal caverns are strange features where you have hyperreflective faces, just hyperreflective faces, and you can see there are overlying areas where there's severe RP chorea capillary damage. So again, a beautiful study now that says that choroidal caverns are not empty and they're likely to contain lipid proteins. The significance is unknown. So thank you for a patient listening, and I think I've just finished on time. Thank you.
Thank you, Dr. Oni, for that excellent talk. I think you tried to cover all the newer biomarkers in dry AMD. I would like to call upon Dr. Darai Shroff for his next presentation. He will be talking about certain new terms in wet AMD. Dr. Darai.
Good morning, everyone. Can you see my slide?
We can see you. I mean, yeah.
I'm not getting this slide. 1 second. Can you have the next talk? Somehow it's not opening. I'll just.
Yeah, okay. So, I'd like to invite Dr. Manoj to give his talk upon, if Dr. Manoj, are you ready?
Yeah, I'll get ready, yes.
Okay. So we are, the next talk by Dr. Manoj, who is a senior veterinary consultant at Chaitanya, and he's a prolific retinal surgeon, and he's been trained in Arvind Eye Hospital and is the head of the department in Chaitanya. And he will be talking to us about the structural changes The surgical features affecting the macula and the interesting tomographic features associated with them. Dr. Manoj.
I hope you can see my slides.
It's visible.
Yes.
Thank you, Dr. Unni, for giving me this opportunity. I'll be actually introducing you to some new terms in retinal imaging that is mostly related to surface disorders. So let's start off with LHEP. LHEP stands for lamellar hole associated epiretinal proliferation. Now, this is described by Pang et al. In the year 2014. This refers to the presence of an abnormal reflective tissue on the retinal surface around lamellar macular holes. They're characteristically seen on spectral domain OCT. As you can see here, these represent the LHEP. And it's important to differentiate this from epiretinal membrane because they look very similar to epiretinal membranes. While epiretinal membranes are thin and highly reflective, and they are characterized by underlying tractional retinal folds and cystoid changes, LHEP is characterized by thicker reflective tissue. They are seen around lamellar macular holes predominantly, and sometimes you can even see these deposits within the lamellar macular hole. And often they do not have any underlying tractional folds or cystoid changes. In practice, what I do is I look at this black on white images. If this is very useful to differentiate epiretinal membrane from LHEP. The ERMs, they appear as these black, reflective lines, whereas LHEP, they appear as fleshy gray lesions. So this is a very useful way to differentiate this on the imaging. One should also know that this is not seen on clinical fundus photographs very clearly. One needs to resort to multicolor imaging, especially the blue reflectance. The blue reflectance picks up these proliferations very clearly. Now, why should you know about LHEP? Now, eyes, lamellar macular holes with LHEP, they have larger hole diameters, and more importantly, they have a high incidence of ellipsoid zone defects, and therefore poor vision when compared to lamellar macular holes without LHEP. If you look into the literature, if you look at the natural course of LHEP lesions, they kind of remain pretty stable for a pretty long time. Now, in terms of surgical outcomes, there are a lot of conflicting reports, but the general consensus is that surgery offers no great anatomical or visual outcomes in these patients. Now, surgery needs to be done if an LHEP is associated with a full thickness macular hole, or when you encounter a lamellar macular hole with LHEP progressing to a full thickness macular hole, or if there is a progressive visual loss or metamorphopsia associated. Now, what is described is that one should not be aggressively peeling at these membranes, because what happens is this tissue is often connected to the outer and middle layers of the retina. So when you try to aggressively peel these membranes, you may end up converting a lamellar macular hole into a full thickness macular hole. These tissues have to be gently dissected, and around the fovea, one could see this perifoveal crown-like phenomenon. This is called the perifoveal crown. And there are also techniques where people have described that you just need to trim these at the edge of the hole margins and just leave it there. There are also techniques where they have embedded the LHEP along with the ILM into the lamellar macular holes. Now, though the term lamellar hole associated epiretinal proliferation is quite popular, the fact that they are seen not just in lamellar macular holes, they are seen in a lot of non-lamellar pathologies, hole pathologies, and the fact that immunohistochemistry studies have shown that they are primarily of Muller cell origin. A better term would be Muller cell proliferation. Now, coming to the next entity, central bokeh abnormalities. Now, central bokeh refers to a small circular island of sparsely arranged cones linked with specially arranged Muller cells called the Muller cell cone, which is described by Gass et al. Earlier. Now, there are two types of Muller cells. The central Muller cells are more vertically oriented when compared to the Z-shaped morphology of the parafoveal Muller cells. Now, whenever there is surface traction that happens, the traction is, it goes on to the central Muller cells. And there are a lot of changes that happen in the central outer retinal region. And these changes are collectively called the central bokeh abnormalities. Initially, what happens is there is the central cones are separated from the retinal pigment epithelium. That fuzziness when you see an OCT at this stage. Later, what happens is there is subretinal fluid accumulation there. And later the photoreceptor debris accumulation that happens at this site, which is seen as vitally formed deposits centrally. Now, this has been described very well on OCT. All these are collectively referred to as central bouquet abnormalities. The first stage, there's a cotton ball sign, there's the fuzziness of the photoreceptors, then there is subretinal fluid accumulation, and finally there is vitally formed deposition. All these changes sometimes can be progressive. So as this picture showed, when there is a progressive traction of the epiretinal membrane, these changes may shift from one stage to another. And with progression, also studies have shown that there is a progressive loss of the underlying ellipsoid zone and therefore progressive loss of vision. Now, these central bouquet abnormalities are not just seen in surface traction abnormalities. Whenever there is intraretinal fluid and stretching in the Muller cells, as in vascular disorders, there also you could see these changes. So what is documented is that relieving these central Muller cell traction surgically could resolve or reverse some of these entities. Now coming to the next entity, if you look at this left side OCT pictures, these are all pictures of epiretinal membrane with varying degrees of inner retinal and full thickness retinal distortion. These are the typical epiretinal membranes. But what you see on the right side, these are images obtained from younger individuals, where you see preretinal gliosis, there is intraretinal thickening and infolding. And this is from a condition, the combined hematoma of the retina and the retinal pigment epithelium. They look very similar, especially when you see a patient later on in life. So omega sign is a sign that is described recently, which is a sign to differentiate, which helps you to differentiate this from the typical epiretinal membranes. Now this is an enlarged picture. Do you see the omega sign here? What essentially this means is that there is an outward push of the OPL by the retinal hematoma, and along with this there is an inward contraction along the retinal surface by the epiretinal glial tissue, and this leads to the typical omega sign. Now, Shields et al. Had earlier described these mini peaks and maxi peaks. Mini peaks, refer to this inner retinal tractional changes, whereas the maxi peaks denote this full thickness retinal traction vertically and laterally, and omega sign probably is a representation of these maxi peaks. Now, the implication is that whenever we see an ERM, especially in the end, one needs to rule out retinal hematomas, which because we often resort to OCT and it's a very close mimic. We need to rule out combined hematoma of the retina and retinal pigment epithelium. This because a surgical option is not a great option in these patients. The results are not always very consistent. The next entity I would like to talk on is the posterior vitreous base. We all know that vitreous base straddles the ora serrata. It extends 1.5 to 2 millimeters anterior to the ora and 1 to 3 millimeters posterior to the ora. The portion posterior to the ora effectively can be called as posterior vitreous base. Now, this posterior vitreous base histologically has been shown to increase in width as age increases. It can increase from 1 millimeters to up to 3.7 millimeters by age 70. And this widening result, there is an abnormal vitreoretinal adhesion that happens in this posterior vitreous base. By definition, an abnormal posterior vitreous base is one where the posterior edge of the vitreous base is more than 3 to 6 millimeters from the ora serrata. And this 6 millimeters meaning it's almost the region of the vortex vein. So when the PVD is being induced during surgery, if you cannot detach the PVD beyond the region of the vortex vein, one should suspect that you are probably dealing with a patient with abnormal vitreous base. The importance of knowing this is because nearly 1/3 of these eyes end up with newer intraoperative breaks during surgery. Also, there is a higher incidence of recurrent retinal detachments in these eyes. So the surgical tip is that aggressive PVD induction should not be done in these eyes. One should be performing an indentation vitreous base shaving, either a traditional approach or a torpedo light aided vitreous base shaving. Use of IVTA helps in identifying this residual vitreous. Doing a pneumatic or interface dissection also may help. Son et al. Recently in an article, he has suggested that placing a broad buckle in patients undergoing retinal detachment may be useful, and in eyes undergoing vitrectomy, he has suggested doing an endolaser barrage. Coming to the last entity, ectopic inner foveal layers. Now, this again is an entity that is seen in epiretinal membranes. IFL is defined on the spectral domain OCT as a presence of a continuous hypo or a hyperreflective band extending from the inner nuclear layer and the inner plexiform layer across the central foveal region, and that's a catchword, the central foveal region. This finding is now part of the ERM classification. It's part of the stage 3 and stage 4 epiretinal membranes. Now, why is IFL identification important? It is important because it is an independent biomarker of poor visual acuity in patients with epiretinal membrane. In terms of surgical outcomes, both anatomical and visual outcomes are poor in these eyes. So the consensus is that vitrectomy is not very useful in terms of visual acuity, regaining good visual acuity in patients with IFL. As you can see in this picture from the article, this is a grade 4 epiretinal membrane which underwent surgery, and you see at the end of 12 months there is still persistence of IFL and the foveal contour is not regained. So this is what effectively happens in these patients. So the take-home message is that we may need to operate on ERMs much early, even before they develop IFL, because studies have shown that vitrectomy is beneficial only in the non-IFL eyes. Thank you.
Thank you, Dr. Manoj, for that very in-depth analysis of that surgical issues of the macula, and thank you for keeping in time. Is Darius ready?
Yes. Sorry for that. I think it's visible now.
Yeah, Darius is the chief vitreoretinal surgeon, one of the senior vitreoretinal surgeons at Shroff Eye Center, and he will be talking us to the terms associated in exudative AMD. Over to you, Darius.
Good morning, everyone. I'm really grateful to Dr. Onni for this opportunity. And I thought let's break these interesting interconnected terms into 3 components. So we'll talk about the good, the helpful, please note the question mark after helpful, and the ugly. Stable SRF being stable SRF, multi-layer PED being good, quiescent CNVM and choriocapillaris recapitulation being very helpful, and the SHREM, of course, being the ugly bad boy of the day. So let's start with stable SRF. Many studies have shown a robust association of IRF to be worsening visual acuity, but the presence of SRF is paradoxically shown to correlate with better vision compared to a completely dry macula. So these are recommendations for experts. And what is stable? How do you define stability? So this number keeps coming up when the persistent fluid is less than 200 micron, and there's no further worsening of the vision, etc., and everything seems stable. This is when they define SRF to be stable. And this magic number of 200 micron is also seen in the pivotal fluid study, where they found that they were tolerant of any fluid SRF below 200 micron at the foveal center. And these patients achieved vision which was comparable compared to the stringent criteria. So this has now found its way into clinical practice also, where fluid SRF is being tolerated if it's stable. And this is a clinical trend survey from 2019 URetina. And it found that 71% of delegates do accept small amounts of fluid. So let's see how it translates into the real world. So this was a study. It was from, I think, the Harvard Medical School in Boston. And they found that these were typically irregular PEDs with SRF. There was no leakage on FFA, but the OCTA showed a CNVM. And they had up to 10 years follow-up without anti-VEGF. And they found that this is a subset of AMD patients with SRF who are better managed by observation because of a presence of an indolent, mature, and stable vascular network. So this is one of the images. You can see the time domain OCT down here, which showing the fluid, and 10-year follow-ups with the spectral domain OCT, and the corresponding FFA and the CNVM seen beautifully on the OCTA. And these were asymptomatic patients, vision 20/25 or even better. And they said, observe these until there's a symptomatic change, drop in vision, or a new subretinal hemorrhage on fundus exam. Why is SRF good? SRF may act as a buffer against the direct toxic effect of the CNVM or the diseased RP. It may be a biomarker for a more benign disease associated with the type 1 CNV, acting as trophic support to the outer retina. And this is something that's going to come up again and again in my talk. It may reduce the presence or the risk of vision threatened atrophy. And very interestingly, in the article from Retina, Christenberry found that macular atrophy progresses significantly slower in the areas corresponding to the PED, which actually contains the type 1 CNVM flow. So this is something important and we can remember this. Second entity, which is good, multilayer PED. So the multilayer PED appears as organized layers of hyperreflective bands between the RP and the Brooks within a vascularized PED. And it is seen more often with multiple anti-VEGF use and is protective in nature and may present further degeneration. So basically what is thought is chronic VEGF type 1 CNVA may evolve into a multilayer PD, and it protects, gives a protective effect to the overlying RP and outer retina. This is how it looks. You can see the multilayer laminar structure under the RP. And why do these form? Basically, this is the layering of the hyperreflective bands, which are fibrovascular and fibrocellular beneath the RP. And it leads the increase in anti-VEGF therapy leads to gradual increase in the lamellar component. So this is a case. I would see the lowest figure here. You can see beautifully, you can see the multilayer PD. And these patients are found to have good visual acuity as the neovascularization and the cicatricial process is suppressed by the chronic anti-VEGF therapy. And the viability of the photoreceptors is maintained through the preservation of the RP in this good entity. Let's see some things which could be useful. So a very interesting entity is now the quiescent CNVM. This was originally described by Dr. Kirkes in an IOS article in 2013. They're also called non-exudative or subclinical. These are asymptomatic, previously untreated CNVMs showing absence of intraretinal or subretinal exudation in 2 consecutive visits. And over time, they enlarge in size, but there's not much of RP retinal thickening. And in this study in 2013, they said that a lot more research needs to be done. They found some changes in microperimetry with this entity. And of course, this has now been studied in a pivotal study by Dr. Phil Rosenfeld and colleagues published in Ophthalmology. And they studied 11 eyes with asymptomatic intermediate non-exudative AMD, and all these patients had a type 1 CNVM in the fellow eye, which is how they located these patients. And in 3 of these eyes, the ICG showed a plaque with no evidence of anything on a FFA or OCT. But the SSOCT showed an unambiguous type 1 CNVM corresponding to the plaque. So these are cases which we now just think as drusen clinically. But if you do a swept source OCT, look, lo and behold, under this, you can see a beautiful type 1 network. What does all this mean? What are the concerns? There's concern that these asymptomatic lesions should not be aggressively treated with anti-VEGF before we know their natural history. But it does seem reasonable to assume these eyes are going to be more likely to progress to active symptomatic forms of exudative AMD. The real crunch question here is that these asymptomatic lesions may be providing nutritional support for the overlying RP and photoreceptors. So to prevent atrophy, we should not be over-treating these patients, just keeping them under close follow-up. Choreocap, this is one of the long words which Dr. Oni has given us to work on, but basically it's a concept, I think, more than something to see. Basically, physiologically, the source of oxygen and nutrition for RP and outer retina is, of course, diffusion from choriocapillaries. And if the RP is hypoxic, it secretes VEGF, which causes aberrant angiogenesis. So it was found that the CNV network, which has been reported to have capillary-like vasculature with fenestrations resembling the native choriocapillaries, supporting the hypothesis that these membranes have the capacity to recapitulate the failing choriocapillaries. So that is the key message in this. So again, we come back to the same point that the type 1 MNV, the neovascularization, may be beneficial. And this idea has emerged over many years. I think Claus and Green from Wills Eye Hospitals considered the type 1, they were pathologists who did ocular pathology, as a granulation tissue. And they found a reparative mechanism involving proliferation of this. And it is found that with OCTA, the quiescent or subclinical CNVM is correlated to ICG plaques and protects against atrophy. And these lesions remain stable and non-threatening for years. Vision may be preserved and these should be monitored accordingly. Last but not the least, the ugly. So SHREM. What is SHREM? SHREM is a morphological feature seen on SD-OCT as a hyperreflective material between the retina and the RP. It's a whole basket, like a waste paper basket. It's full of different things like neovascular tissue, fibrosis, exudate, vitelliform material, hemorrhage. All of these could constitute SHREM. Let's see an interesting case of a 50-year-old man who had multiple myeloma with light chain disease, but he presented with a type 2 CNV. You can see the SHREM here. Post anti-VEGF, it has reduced and the patient has done well. But we must remember that eyes with SHREM, they do worse. And the poor prognosis in SHREM are SHREM with well-defined boundaries, high reflectivity, or thicker SHREM. So this is another patient who doesn't budge. The SHREM doesn't budge with anti-VEGF. So you can see we've given 3 injections. There's no, I think it was frankly referred to us, but this was the post-injections. There was no change in this until we did a multimodal imaging, and we found that it was actually a vitelliform lesion with the increased AF signal. So this is a patient with SHREM because of vitelliform deposit. There's another concept of SHE, which hasn't been really given to me, Dr. Uni, but if it's exudative, and that is basically because of a network or a vascular SHREM. So these are the networks we can see, and the SHREM has reduced here after anti-VEGF because it's a vascular, and it could be caused by a neovascular tissue, which could be type 1, type 2, or type 3. Basically, it's a manifestation of varied macular disease processes, and in AMD, it's associated with frequent scar formation and a poorer final vision. So to conclude, we have studied these interesting subsets of neovascular AMD under the title of good, helpful, and ugly, and hope this helps us to remember these a little more. Thank you so much.
Thank you, Dr. Shroff, for that presentation. And can you stop this? Oh, yeah, thank you. And it was wonderful to put it in the right perspective. It was really nice, and that is going to be a really good remembrance tool for people to understand the various lesions. So now I'd like to invite Dr. Anand Rajendran, who is the head of vitreoretinal services of the Aravind Eye Care System in Chennai. He is an all-important figure in the Vitreoretinal Society of India, and a key academician and a wonderful speaker. Dr. Anand will be talking to us about some of the vascular features.
So thank you, Uni, and thank you for having me in this wonderful session. So I'm going to be talking to you about imaging biomarkers, and these are the ones. So, with cutting edge advances in OCT imaging, this is how we're beginning to see macular images. It's almost optical histology. And to the extent that imaging has now become an almost integral component of a definition of a biomarker, which is useful in helping us diagnose and prognosticate macular diseases. I'm going to be focusing in this segment on biomarkers that are more relevant to diabetic macular edema. My other esteemed colleagues have covered that with AMD and will do so also. So DRIL, the first one, is disorganization of the retinal inner layers as defined as a horizontal extent on STOCT within which any of these boundaries are indistinguishable. Ganglion sun to inner plexiform layer complex, inner nuclear layer, outer plexiform layer. DRIL is a standalone entity which is assessed independent of intraretinal cysts, ERMs, and other OCT evident pathology. Now, DRIL is typically seen in active diabetic macular edema, skytic in this case, and with the ellipsoid zone ELM discontinuity seen, and an ERM also thrown in. But it's also seen in isolation, and in such cases, it can be a surrogate marker for macular edema having been there. Now, Jennifer Sun's group with Lloyd Elo from the Joslin Center, they were one of the first to look at this, and they, in a retrospective study, looked at about 120 eyes with baseline center involved DME with SDOCT at baseline 4 and 8 months. They looked at the foveal central 1 millimeter wide retinal area and looked at DRIL and a number of outer retinal segment biomarkers, including hyperreflective foci. And they found an increase in DRIL in 4 months, which is associated with poor acuity at 8 months. But more interestingly, they found multivariate model, which is a composite of 4-month change in acuity, DRIL, and ELM disruption, which was the most predictive of 8 months visual acuity status. And they went on impressively to quantify it. At 4 months, they found that a 250 micron increase in DRIL, none of these patients had a one-line improvement. When they bumped it up to 300 microns, they found a 300 micron increase in DRIL was associated with worsening in acuity with all patients. On the other hand, a 250 micron decrease or improvement in DRIL, none of them had a one-line decline. 77% had improvement one line. Radha Das et al. From Usha Chakravarti's group in the Belfast University looked at a cross-sectional observation study with 80 individuals. They looked at 9 different parameters. drill included and the outer retinal biomarkers. So they found that the odds of having drill were greater in eyes with disrupted external limiting membrane, disrupted ellipsoid zone, presence of epiretinal membrane, increase in foveal retinal thickness, and proliferative diabetic retinopathy. But the odds ratio was strongest with disrupted ELM and proliferative diabetic retinopathy. They found that mean equity decreased by approximately 6 letters for every 100 micron increase in the average global drill. Radwan did a very interesting study also. They looked at a retrospective longitudinal cohort study where they looked at 70 eyes with center-involved macular edema that had resolved during the 8-month period. They looked at the central 1500 microns, looked at drill, OR anomalies, and correlated to equity. They were grouped on the basis of macular edema, diabetic versus non-diabetic. They looked at the drill resolution profile in these patients and the influence on equity with DME, the resolver. So they classified into 4 early resolvers, those that had resolution of more than 50% of the baseline drill length at the first or second visit and remained stable or improved by the end of the study. Then they had late resolvers, the same thing, but resolution in the 3rd or 4th visit, a little later. Then they had the third inconsistent, resolution of more than 50% of the baseline drill length at any point with subsequent recurrence. Persistence was those that never showed resolution of more than 50% of the baseline drill length at any time during the study, despite resolution of DME. Not surprisingly, they found that the best equity gainers were those with no baseline drill, followed by early resolvers, then late resolvers, then inconsistent, and finally the worst were those with persistent drill. In other words, if you have 100 patients where DME is resolved, those that will have the best equity will be the ones where drill has resolved the fastest. So the pathogenesis postulates correlation hypothesis for drill. It is hypothesized to result when bipolar axons snap after their elasticity limit has been exceeded due to the mechanical effect of the edema. Collateral damage also to amacrine cells, horizontal cells, inner retinal breakdown, and drill is better correlated with visual acuity improvement, even better than the baseline visual acuity. So it's a better surrogate marker of final acuity. And this correlation was stronger with non-DME macular edema like RVO macular edema, uveitic macular edema than DME itself, because DME has actually many other chemokines active possible. And it predates all the OR abnormalities that we're talking about, ELM, EZ, etc. Now, parallelism is a mathematical tool that's come very recently, very interesting one, to evaluate the anatomical congruity of the photoreceptor RPE complex. It is a parameter reflecting the mutual orientation of these segmented lines on SDOC, calculated using line segments generated by filtering and thresholding the original ML with this complex formula. It's binarized to range from 0 to 1. And obviously, more parallel lines have higher parallelism. So this is how they constructed a horizontal line scan from SDOCT image, magnified central 1000 into 1550 micron area, filtered application of a bandpass filter for noise reduction and enhancement of these line segments, use a thresholding with binarized image after using what's called the Otsu's thresholding method for automatic binarization, and then you generate this skeletonized image. Now, Uji et al. Did a retrospective study with 90 DMEIs and 30 controls, used these parallelism constructs and tried to interpret the relationships of interrelation with photoreceptor status, ELM integrity, EZ integrity, and the outer retinal hyperactive foci in relation to the equity. And they classified the inner segment ellipsoidal line as a complete line in the fovea was inner segment ellipsoidal line plus a discontinuous line, inner segment ellipsoid plus minus. When it could not be detected at all, it was inner segment ellipsoid minus. The same thing was done with ELM, ELM plus minus, ELM minus. And these are the URLs for the softwares used. So some examples: patient with good congruity, equity 2025, foveal thickness 440 microns, no HRF in the outer retinal layers. Note that ELM plus and inner segment ellipsoid line disrupted plus minus. Parallelism quite good, 0.689. Example of one with a poor equity 2050, foveal thickness 640, 2 microns. HRF is present in the outer retinal layers. So there is inflammation probably happening right there. ELM plus minus, inner segment ellipsoidal line disrupted, again plus minus, fairly poor parallelism, 0.492. So they found that both logmar equity and parallelism were significantly reduced in eyes with DME compared to normal eyes. They also found strong correlation, ellipsoidal line and ELM integrity and absence of the outer retinal layer hyperretinal foci with parallelism and visual acuity, as you can see in the graph. One advantage to this technique is it's faithful to the original image and avoids issues related to segmentation errors. Capillary macroaneurysm, another fairly recently understood entity described by Boris et al. First, recommended the word telangiectatic capillaries to avoid confusion with the retinal artery macroaneurysm, is associated with chronic macular edema because of vascular causes, vascular occlusions, fairly refractory to anti-VEGF treatment. So this shows how ICG beautifully delineates the progressive filling of the capillary macroaneurysms. ICG also helps in distinguishing micro from these macroaneurysms. You see microaneurysms diminish and fade away, whereas capillary macroaneurysms increase conversely in intensity and size. Distinguishing FFA, ICG, and OCT. FFA is not really useful. There's a diffuse leakage which kind of camouflages this. ICG you saw, beautiful light filling. And OCT shows a hyper-reflective wall with lumen containing variable reflective material. Microcystoid macular edema, again something which has come up recently, is defined as microcysts in the inner nuclear layer of the retina. Most acceptable pathophysiology, Muller cell dysfunction, seen in a wide spectrum of disease like AMD, DR, RVO, etc. An example here from severe NPDR. So in the MACTEL group also looked at this. They looked at a cohort and they found MME in about 6.4% of their cases. Mean number was 12.9. Most common location, again, they confirm inner nuclear layer. Least common affected region, INQ, inferonasal quadrant of macula. Mean diameter was 31 microns, ranging from 15 to 80. And they found that these were almost entirely distributed within the assumed macular area on blue light reflectance. Now, Govetta et al. Did something interesting. They looked at MME in ERMs and influence of glaucoma, and they found that MME was found in 20% of ERM cases. Incidence increased with the stage of the ERMs and with the stage of glaucoma. In glaucoma cases, MME may be a sign of retrograde maculopathy, and while it was predominantly seen in the INL, they also found pseudocysts in the advanced stages. And they found that MME resolved significantly only in non-glaucoma cases, and there was persistence of this MME in glaucoma cases. That's why it's important when we see this with the ERMs or not, look for glaucoma coexistence. Also found in systemic conditions like multiple sclerosis. Ulano did something interesting. Look for these in post-vitrectomy gas cases as causes of unexplained visual loss. They found it in 2.5% of their cases with vitrectomy gas, macula on RDs. Mean median post-op acuity was finger counts. All eyes had this MME and reduced thickness of both macular ganglion cell and retinal fiber layers. The absolute central scotomas. Surprisingly, none had photoreceptor structural damages at all. Hyperreflective foci, we already talked about it, previous speakers. HRF, small, discrete, well-circumscribed dot-shaped lesion equal or greater reflectivity than the RPE band on SD-OCT in the outer retinal layers. An example of HRF in PDR DME. And first described by Balls et al. In patients with diabetes. A sign of vascular permeability, hyperpermeability might correspond to deposited lipoproteins, lipid-laden macrophages, debris of photoreceptors, and RPE hyperplasia. And Huang et al. Did something very interesting. They looked at cases of DME and RVO in a retrospective study, and they defined it similarly. And they put a number to it, 20 to 40 microns. This is the size. So these patients all had 3 injections of bevacizumab. Non-responders from these were treated with Ozurdex. They found that the HRD number was more in bevacizumab non-responders than responders. 75%, 3/4 of the bevacizumab non-responders responded to Ozurdex. HRD number conversely was more in Ozurdex responders than non-responders, so opposite to bevacizumab. And they postulated that HRD was possibly a sign of a marker of inflammation because of the great response to steroids and microglia and Muller cell debris to be brought. So they suggested that there was a therapeutic role, therefore, of steroids in anti-VEGF non-responders. So HRF also increases with the stage of diabetic retinopathy. From no DR to PDR, you see this number of spots increasing. And it's an early sign of blood-retinal barrier breakdown. Some of the postulates suggested Muller cell breakdown products, RP cell migration, but what we believe now is it's an incipient form of heart disease. So here you have HRF, an example, in HRF and DME improving and regressing with anti-VEGF therapy. So it's considered a nascent form of heart disease. It's almost considered like sub-threshold disease, signals BRB breakdown, and in AMD, it's the first to resolve and the first to recur in a relapse. In DA patients, we can see. Outer retinal abnormalities, integrity of outer retinal layers is a direct indicator of the health and the retinal photoreceptors and RP, photoreceptors length and integrity. So cross length was significantly lesser in eyes with diabetic retinopathy or DME compared with healthy subjects or diabetic patients with no retinopathy. So this is a case where of chronic DME, where you can see progressive loss of the ELM over time without treatment. And this is an example of a chronic DME case in one of our patients where there showcases ELM EZ resilience. This patient was lasered elsewhere, came in 10 months of, because of the pandemic, there was a delay. Patient came here after 10 months, 5 by 6 we start off with 5 injections in 7 months, 4 ranibizumab, last one was bevacizumab, and you see how the recovery of the ELM EZ. So the ELM EZ can be resilient if you treat, and you should treat early. The BRBs and the OR microcosm nexus, you see, I'll just put it in short. In diabetic macular edema, the pathology comes from the top down. So the drill and the IP-INL area is affected first compared to the ELM. AMD, it's the other way around. Outer retinal tubulations, I think Uni has already kind of touched upon this. It's degenerative cystic photoreceptors. And this is the pathology, focal disruption of the PR layer in vaccination of remaining cells and lateral contact and feeds ORT. Just a small example of a case, a chronic case with an ORT there. Treatment, the CNV reduced, but the ORT is actually increased and coalesced to form a giant ORT. You can also see this in geographic atrophy cases. So in summary, drill, an early sign of loss of inner retinal architecture, the bipolar cell snap happens. Parallelism is a mathematical model where there's architectural congruity showing up the PR-RP complex. Capillary macularism, chronic macular edema. In those cases, you'd find this. IC373 is better than FFA. Lasers may be indicated. MME, microcystoid macular edema, microcysts in the INL, molar cells implicated, hyperrefractive foci, form of nascent hard exudates, inflammatory marker perhaps, and is a good prognosticator. Outer retinal complex, the EZ, ELM, the cross showcase the photoreceptor integrity. Thank you.
Thank you, Dr. Anand, for that very exhaustive talk. I'd like to invite Dr. George Manyat, who is a very emphatic and convicted speaker. He is the perfect person to take us through some of the most confusing terminologies in OCT. Now, Dr. George is an integral part of the Aravind Eye Care Group in Coimbatore.
Yeah, thank you, Unni, for this nice introduction. So I'll start with the pachychoroid spectrum of diseases. This is a spectrum of diseases to which the common thing is an abnormal and permanent increase in choroidal thickness. It is not just this diffuse or focal increase in choroidal thickness on enhanced depth imaging, but you also look for the dilated outer choroidal vessels or pachyvessels compressing the overlying choroid capillaries, and reduced fundus tessellation, and ICG showing early phase dilated pachyvessels, and mid or late phase showing choroidal hyperpermeability and leakage. So the first entity is a pachychoroid pigment epitheliopathy, PPE, and it is nothing but non-specific RP changes associated sometimes with small serous pigment epithelial detachment. And it is best appreciated on fundus autofluorescence associated with ICG choroidal hyperpermeability, thick choroids, but there is no serous macular detachment. So it's considered to be a formiferous state of CSR and seen in the fellow eyes of CSR. The next entity is central serous chorioretinopathy, where there is a serous macular detachment associated with RP leaks and pigment epithelial detachment, usually young males and type A personality. The OCT typically shows the subretinal fluid. In this case, there is a hyperreflective material, the fibrinous material associated with a serous pigment epithelial detachment. The fluorescein angiography in an acute CSR shows a point leak. Here it is an ink blot or smokestack in few of the cases. And in chronic CSR, you see this kind of typical diffuse RP epitheliopathy kind of leakage or macular RP degeneration or teardrop kind of RP tract. And ICG, as we already mentioned, shows these dilated pachyvessels and mid-phase choroidal hyperpermeability and fluorescein diffuse leakage. These are all classic for chronic CSR. Now, why you need OCT angiography in a CSR? Because the type 1 neovascularization in chronic CSR or in a de novo pachy neovasculopathy, the FA and ICG are sometimes not picking up the neovascularization because of the diffuse leakage on FA and ICG. And the studies have shown that the dye-based angiography picks up only 30% of these subtle neovascularization, whereas Octa picks up in 95% of the cases, usually associated with this flat irregular PEDs called FIBD. So let us look at a typical case example. A chronic CSR in the left eye, 2 years, and referred for PDT for subfoveal diffuse leakage. The other right eye shows a typical pachychoroid on Swepsore's OCT, but the left eye shows a flat irregular PED that is fibed with subretinal fluid. You can see the subretinal fluid and a flat irregular PED overlying pachy vessel, and there is a sub-RP hyperreflectivity also. The Octa shows superficial and deep segmentation normal. Avascular retina picks up this beautiful tangled filament kind of CNVM. And this CNVM overlies the area of fibed or flat irregular PED, the type 1 neovascularization in pachy setting. So Octa is a safe and highly sensitive test to pick up this subtle neovascularization. So this is what I said, in the absence of a chronic CSR setting, pachychoroid disease with subretinal fluid and a type 1 neovascularization, we call it pachy neovasculopathy or PNV, which has a thick choroid, subtle shallow PEDs, and the fluorescein showing a stipple leakage, and ICG angiography showing the hot spot, suggesting a neovascularization. So, but this is not unlike AMD, we have a thick pachychoroid and a type 1 neovascularization. OCT angio again is a sensitive tool to pick up these pachy neovasculopathy CNVs overlying pachychoroid. Treatment is usually aflibercept or other anti-VEGF injection. So the last entity in pachychoroid disease spectrum is PCV, or polypoidal choroidal vasculopathy. Is a serosanguinous maculopathy, clinically sometimes seen as orangish subretinal nodules, and ICG is the gold standard, picking up this early hyper nodules on ICG first minute usually, and late leakage or late washout, and also a feature called late geographic hypercyanescence. This is specific to PCV, unlike neovascular AMD. The other typical features like a notched PED with polyp on the undersurface of the RPE, a sharp peaked PED or a thumb-like PED, or a double layer sign harboring the branching vascular network between the separated Brooks and the RPE. These are all classic OCT signs, and have around, the new consensus group have found around 82% non-ICGA OCT diagnosis of PCV compared to the gold standard ICG. So it is quite an important feature to understand on OCT, and Octa also picks up this branching vascular network, but polyps being low flow lesions are poorly visualized on OCT angiography. Coming to a new variant of pachychoroid disease, the peripapillary pachychoroid syndrome, wherein all these features are confined to the nasal macula. For example, you can see the intraretinal subretinal fluid in and around the optic nerve. There is a preferentially nasal macular choroidal thickness, unlike the temporal usual thickening. A mild disc leakage and peripapillary RP atrophy, and the pachy vessels and the choroidal hyperpermeability usually confined to the peripapillary area. So this is a new variant of pachychoroid disease. And also lastly included into the pachychoroid disease spectrum is a focal choroidal excavation, or FCE, which is a distinct area of sharp choroidal excavation on SD-OCT in the absence of staphyloma or other scleral thinning or choroidal thinning. So it is two types: a conforming type where the retina is attached to the RPE, and a non-conforming type where the retina gets detached from the RPE. And in this hyporeflective spaces may be SRF with some amounts of shed outer segments of the photoreceptor. Initially thought as a congenital defect, but now we know it could be acquired. FC could be associated with CSR, PCV, or CNVM. So here is a typical young patient with subretinal hemorrhage at the macula, but his OCT reveals that the type 2 CNVM overlies a focal choroidal excavation. But the relevance is that this new entity usually stable for a long period of time, but it could be associated with CNV, PCV. So careful long-term follow-up is very important, and extremely responds very well to anti-VEGF. Maybe 1 or 2 injections may suffice for the treatment. Let us switch to neovascular AMD. Instead of a thick choroid, you're looking at a thin choroid and elderly patient. SIRE is a shallow irregular RP elevation on OCT. And this could be a telltale sign of a non-exudative CNV harboring in these shallow PEDs. So this is called a double layer sign of AMD, which is usually the RPE separation is less than 100 microns in height and linear dimension is more than 1000 microns. So this comes in the setting of what Unni already described as a drusenoid PED or intermediate AMD that we see. And natural history has shown that 25% progress to CNVM in 5 years. So this is a typical case scenario wherein one eye has wet AMD. There is a other eye showing only a drusenoid flat irregular PED overlying thin choroid. And you see this subtle neovascularization on octa, which grows over 6 months and 12 months, where the patient becomes symptomatic and subretinal fluid has come. So it is important to look for this SIRE lesion and early. So we pick up this neovascularization, only close follow-up is required. Earliest signs of exudation, treat with anti-VEGF therapy so that the patient maintains a 6/6 vision even in that stage. Next entity is a dome-shaped maculopathy or DSM. It's a convex anterior protrusion of the macula within the concavity of a posterior staphyloma. In high myopic eyes, it's seen around 10% of the patients. So it is a great mimicker of CSR because you see these point leaks and RP degeneration. It's all mimic CSR, where ICG is the catch here. Unlike the previous cases we saw, there is no choroidal hyperpermeability. It's a hypocyanescence seen on ICG angiography. So the dome could be horizontally or vertically oval. So single OCT scan may not be sufficient. You need a radial OCT scan to pick up this lesion. And PDT is a promising treatment in around 60% of the cases, but only thing is 2 or 3 sittings of PDT may be required. So it's a diagnostic challenge, dome-shaped maculopathy, great mimicker of CSR. OCT radial scans and ICG is the catch here to diagnose. It has a waxing and waning clinical course with long-term visual deterioration, but PDT is a good treatment option in this condition. So switching to vasculopathy now, that's a paracentral acute middle layer maculopathy or PAM lesion. It's a hyperreflective band that is seen in the middle layers of the retina, as you see here, usually seen in older men with diabetes, hypertension, all these things. So it's usually seen as a ill-defined intraretinal whitening, best appreciated on near infrared imaging as a well-circumscribed dark lesion. And now we know that it could be associated with ischemia to the retina. For example, this middle-aged lady with a mild BRVO has 6/6 parts vision, but there is no CME here. But you see that there is a hyperreflective band in the middle layer temporally, and octa reveals a superficial as well as the deep segmentation shows ischemia. So we now know that it's an ischemic origin of PAM, best visualized with near infrared imaging, and octa shows deep and superficial capillary middle layer ischemia. So the last 2 entities, hyperreflective foci, well described by Unni and again Anand. In CNVM or wet AMD, these hyperreflective dots along with other signs like SHREM here could be an activation dot and pigment clump migration and needs aggressive treatment with anti-VEGF therapy. Also, this hyperreflective foci can be seen in serous macular detachment of diabetic macular edema, well described by Anand. This could be precursors of hard exudate clump. So prompt treatment in the presence of hyperreflective dots, and sometimes intravitreal steroids may be more effective than anti-VEGF therapy. So the last entity I would touch upon is a peripapillary choroidal cavitation, which is seen as a yellow-orange inferior peripapillary lesion, usually associated with high myopia and staphyloma. And you can see this hyporeflective cavitation under the RP. And the fluorescein usually shows no leakage, but staining in late phase. ICG is the catch here. It shows all around hypocyanescence during the dye transit. The importance is that glaucoma-like field defect is seen in choroidal cavitation. So the glaucoma has to be ruled out in these high myopic eyes. Rarely it can cause macular detachment and retinoschisis, which may benefit from vitrectomy surgery like in ONH pit that we see. Thank you for patient listening, and thank you all.
Thank you, Dr. George, for that exhaustive and quite an in-depth look into all these terminologies. So now I would like to invite Dr. Abhishek Kothari, who is a prolific surgeon and one of the most tech-savvy ophthalmologists I've seen so far. So he is going to recap what we've learned here with his own twist. So Dr. Abhishek, over to you, please.
Yeah, so good morning, everybody, and thank you, Dr. Unni, for the opportunity to present this. My job has been made really, simple by the previous presentations, because everybody has, I think, really with excellent illustrations illustrated the pathologies. So I think our viewers should not have any problem in understanding, or rather even recognizing it in their own clinical practice. So mine is basically a picture-based talk. I'll be showing pictures and just recapitulating the salient features of most of the entities already presented. So I'll give everybody about 5 to 10 seconds before I move on. What could this be? So this is a case of dry AMD, and if you look at the RPE and these conical projections. So basically, this is reticular pseudotrusion, as I think Dr. Manoj had, as Dr. Unni had said. These are hyperreflective material accumulations. This is between the RPE and the ellipsoid zone. And initially it causes bowing or the distortion of the ellipsoid zone, but then it causes destruction of the ellipsoid zone. The later stages have conical masses and the disrupted external retinal structures. This is a marker for increased risk of GA and wet AMD. And if you have this in your, when you're beginning your treatment, it is a marker of post-treatment atrophy. And it is very frequently associated with type 3 CNVM. The next slide. This is something that Dr. Unni had talked about in the first talk. So if you look at this region here, this is an area of complete RP and outer retinal atrophy. This is basically showing choroidal hypertransmission and absence of RP band, measuring more than 250 microns. And there is overlying photoreceptor loss and outer retinal thinning. When this is incomplete, it is called incomplete RP and outer retinal atrophy, where the RP is discontinuous, but some at least evidence of RP is present. There is also photoreceptor loss and INL OPL dipping or subsidence into the defect. So these are two examples here. If you see the triangle in the first one and in the second image, what could this be? This is a subset of incomplete IRORA, that is incomplete RP and outer retinal atrophy. This is nascent GA, where the RP is discontinuous but present. There is photoreceptor loss, the INL OPL dip, and there is a wedge-shaped or triangular hyporeflectivity seen dipping towards the RP. This is a very strong marker for future geographic atrophy. Now, I think this is one of the most remarkable, or rather, easy to recognize features if you see it on your OCT. If I can mark at least these two features, if you can see my marker here and here. These are basically outer retinal tubulations. They are round or oval structures in the outer retina with hyper-reflective borders and variable intraregional reflectance. Now, what somebody may call it as an intraretinal fluid, but though it resembles CME, what is different between CME and ORT is the presence of hyper-reflective borders. This is not present in the routine CME fluid or intraretinal cysts. These are usually stable over time, and they have no response to anti-VEGF. It's important to recognize them so that you don't keep on injecting in the hope of drying these. They are a sign of chronicity and atrophy, and they are usually related with pretty poor vision. Okay. This is what Dr. Darius had referred to in his talk. If you can see, there is an outer retinal hyperreflective band. So this is basically a subretinal hyperreflective material, or SHRM, SHRM, This is a morphological feature. This has no direct pathological correlation. It's a hyperreflective material located external to the retina and internal to the RP. This can represent CNVM, hemorrhage, fibrous tissue, etc. And mostly it is present in treatment-naive AMD. When you start treatment, the membrane shrinks, the blood goes away. So the incidence of SHREM also reduces. You see less of SHREM. If you have a very large area of SHREM or a very thick SHREM, it's usually a poor prognostic sign. So this is an interesting entity which Dr. Uni had pointed to. This is what is called a choroidal cavern. So if you see, there was a large area of hyporeflectivity in the choroid. It's an infrequent peculiar finding, mostly seen in atrophic AMD, but can be present with wet AMD also. It's a gaping angular hyporeflective cavity in the area that is devoid of choroidal vessels, and it's often seen with punctate or linear hyperreflectivities internally. Choroidal caverns may possibly arise from non-foveal ghost vessels or persistence of stromal pillars. This is a octa finding. So what you can see that there is a membrane or a abnormal neovascularization, but it does not have any exudation on the structural OCT. So this is what we call as a quiescent CNVM or a non-exudative choroidal neovascular membrane. Clinically and structurally, it presents as no activity on a structural OCT. But if you investigate with the octa, 7 to 14% of intermediate AMD may have such an underlying membrane. It is its role is thought to be protective for the RPE, and what they have noticed is if you treat these patients with anti-VEGFs, or if there is a IMD without this kind of a lesion, geographic atrophy is faster in those cases. Geographic atrophy is slower in cases where you have this kind of a quiescent CNVM underlying the RP. 20 to 26 of this may convert to exudative CNVM in 5 years' time, so a close watch is warranted. No active intervention is warranted when there is no leakage on the structural OCT. Now, this is a finding again that we see in several of our AMD patients, especially the ones that have been taking chronic treatment for us. If you look at the characteristics of the PED, this is what we call as a multi-layered PED. It is basically a chronic fibrovascular PED with fusiform shape. It has a fusiform shape. It is basically, it has layers of fibrous tissue. These are visible as organized layers, hyperreflective bands. In between the bands, there is hyporeflectivity. So in conjunction with CNV, this is always present in conjunction with CNV that is adherent to the RP undersurface. And it is mostly seen in long-term, in CNVMs which have a FVPED to begin with and have been on anti-VEGF treatment. So the CNV process is limited to under the RP with no kind of, the retina overlying it being protected. And usually they are associated with good visual acuity. When there is contraction of these fibrous bands, there may be a prechoroidal cleft that is formed. That is a clear area between the choroid and these fibrous layers. This is one of the most, characteristic and a very stark observation if you ever come across a patient with this kind of a OCT. This is what we call as a focal choroidal excavation. Areas of choroidal pitting, they are observed near the macula. Sometimes they can be a little away from the macula also. But you call it a focal choroidal excavation only when it is not associated with scleral ectasia, posterior scapuloma, or a scleral scar. So if you have any of those, then you don't call it a FC. This can cause symptoms like decreased vision and metamorphopsia because of the mechanical bending of the retina and the photoreceptors. And though its etiology is not fully understood, luckily for us, the prognosis in most of these cases is quite good. However, in some cases, it may be accompanied by a choroidal vascular disorder like PCV, CNV, or sometimes even CSR. Now, Dr. Manoj had talked to us about epiretinal proliferation and epiretinal membranes. So, if you any guesses to this? So, this is a scan going through the fovea in a patient with a chronic ERM, and you cannot make out the Henle's layer and the hyperlucidity going to the top of the fovea. What you see instead are band-like structures even over the fovea. So this is what is called as ectopic inner foveal layer. This refers to the OCT appearance of banded tissue resembling, abnormal retinal layers over the foveal region in cases with chronic epiretinal membranes. Usually, again, almost never seen in membranes of a shorter duration. Mostly it resolves with surgery, and This is basically the late stage of ERM with a lot of distortion of the retina. So it is associated with a poor visual prognosis after surgery. If you have a ERM without EIFL, the surgical prognosis is usually better. Now, if you look at the outer retina here, what do you see? There is fuzziness of the ellipsoid zone and the elongated photoreceptor. This is what is referred to as the ulta of ABC, that is CBA, central bokeh abnormalities. It refers to the distortion of the foveal external retinal complex, including photoreceptors, EZ and the ELM. Elongation fuzziness is usually because of the mechanical stretch from the ERM, the traction because of the ERM, or sometimes in retromacular traction. There is sometimes, very occasionally, there is neurosensory detachment also, a very small limited one, and it usually presents in earlier stages of ERM. Usually it has a very good prognosis of surgery. You get very good visual recovery if you, even if you have this preoperatively. Now again, this is an exciting entity. It has become very popular nowadays. If you have a patient who complains of a paracentral scotoma, and otherwise clinically you may not see anything, you may see something on the infrared image, but not very clearly on the fundus image, and OCT shows you a hyperreflectivity of the middle layer. So this is basically paracentral acute middle maculopathy. It shows up as hyperreflective parafoveal bands, but is limited to the inner plexiform layer to outer plexiform layer. Usually it does not extend deeper to the outer plexiform layer. The causative factors are ischemia at the intermediate and the deep capillary plexus levels. And the associations are with some vasculitis and with certain vascular retinal diseases. Usually it resolves with thinning of the affected layers and a scotoma. This has to be distinguished to what this entity is, a similar kind of a hyperreflective band, but present a little deeper in the retina. This is called acute macular neuroretinopathy, and the earliest lesion is usually hyperreflective band at the level of the outer plexiform layer, outer nuclear layer, and then with time it kind of migrates downwards towards the RP, and you when it resolves, it leaves a hyperreflectivity near the in the infrared reflectance, which is best seen, and usually it leaves a scotoma on resolution. Coming to what was talked about the vascularity of the structures by Dr. Anand Rajendran. This is what is a classic case of drill, where you have inner retinal layers disorganized. You cannot find the boundaries between ganglion cell, IPL complex, INL or OPL cannot be identified separately. Very early on, it can be reversed, but later on, it is if it is extensive, it is usually associated with vision loss and a poor prognosis. It is a biomarker associated and predictive of ischemia in DME. This is something that is ubiquitous in several diseases of the retina where you have leakage, and it has to be distinguished from hard exudate. These are hyperreflective foci. If you see, usually hyperreflective foci or dots, as they are sometimes referred to, or sometimes even called spots. HRS, HRF, and HRD are the same thing. They are associated with vascular causes of macular edema, usually in the range of 20 to 40 microns, not more than that. And they have no to very minimal shadowing. They are markers of active disease. And with whatever treatment you institute, anti-VEGF for AMD, or say a steroid or anti-VEGF for DME, they disappear on with treatment. Their number may be correlated to the preferential response. So if you see a lot of them, you may want to give steroids because they are thought to be activated glyocytes, which basically are a marker of inflammation. Now, before I end the last 2 minutes, this is not related to either of the talks. This is a case which actually I discussed with Dr. Darashov yesterday, and he said in an imaging session, this is good to put. This is a gentleman who came to us day before yesterday actually, with a complaint of sudden loss of vision. He had a recorded vision 1 month back of 6/9 with a little bit of cataract. And then 5 days back, he read the newspaper, kept it, and then picked up a novel. And he said, I can't, I was finding it difficult to read, which progressed over a few hours. And this is what the color fundus looked like. The gentleman is not a diabetic, he's only a hypertensive. And the autofluorescence doesn't show anything remarkable. The FFA early phase is quite unremarkable. In the late phase, you see outer retinal staining along the inferior arcade. You know, if you look at the color photo, it almost looks like a CSR. But when you look at the late phase FFA, you see a deep outer staining along the inferior arcade, a little bit of disc staining as well. What do you find on the OCT? If you look at the OCT, you have this hyper-reflective outer retinal band limited to the outer retina alone along the arcade. So these are a series of scans that I've taken along the arcade. You see here some disruption of the external limiting membrane, the EZ and the photoreceptors along all the area that had shown staining. So now I'll open the case for discussion. Any guesses, Dr. Manoj, Dr. George? If Dr.
Is it Azure?
So yes, that was one of the things that that we are considering, Azure, yes. But then again, the kind of the location of the lesion, the picture on the fundus.
The autofluorescence.
Pardon?
The autofluorescence also is not.
Yeah, autofluorescence also is not suggestive of Azure. The autofluorescence is nearly normal.
The outer retinal involvement and a fussiness in the outer retina looks inflammatory, and and the disc staining and radiating from the in and around the disc to the periphery. I mean, my best would be Azure. Probably you could.
Maybe I think the autofluorescence may show a little time to show the changes. I am not very sure of that. Whether there is a delay in the presentation of Azure, but then I thought this is a nice case. Any last comments, Dr. Uni?
I think it's interesting. See, the Azure is a spectrum, and there are things that have been defined like the occult outer retinal retinopathy, where you have outer retinal fussiness also has been described, and it is not area specific. So this falls into actually a section that we have not included, the uveitic entities. But anyway, we've had a small discussion on it. Do we have any final comments from any of our panelists? In that case, yeah, Doctor.
If we have some time, Unik, we can just do a bit of discussion if there's some time left.
Yeah, Manoj can take over. I have to rush to another session, so Manoj can take over. I'd like to thank all our speakers and panelists for a great session, and thank you all. I have to rush over to one. Manoj, you can just take over, and another 5 minutes we have.
Yeah, sure.
Thank you. Thank you so much.
Thank you. Thank you.
Good that we finished most of the discussions before the time, as you had. We had a tight session, and I'm so happy to see that we are before time and we have time for discussion. And
a very wide variety of pathologies has been, quite comprehensively covered.
I think Dr. Uni makes us rack our brains every time. It's like it's always a challenge, but I think we always learn when we make these presentations for Dr. Uni's IC.
So
I just have to leave. Manoj, I'm leaving it to you. Thank you.
Thank you.
Thank you, Unik. We have covered close to around 35 topics in the last 60 minutes. I mean, that's the number of topics that we have covered. Anyway,
and managed to revise them also.
And managed to revise them, exactly.
Record for AIOC IC.
Yeah. For the sake of the delegates, I would like to ask some basic questions. How do you differentiate hard exudate from hyperreflective foci? Dr. Anand, can you just Anand is here? No, I think it's not there.
I think Anand is not there. In for hyperreflective, you're talking about the diabetic macular edema. So I would
for a general practitioner, OCT.
Yes. So basically, we are looking at a precursor lesion here on OCT. It's like a biomarker, wherein 2 points. One is in one subset of DME, that is serous macular detachment. This is more seen in and around the subretinal fluid. These are lipoprotein exudates, and size is less than hard exudates, 20 to 40 microns. And hard exudates would be clinically visible. And OCT, and when you don't see a hard exudate clump, but in a setting of a diabetic macular edema with serous macular detachment, especially when there is an outer retinal discontinuity, it has been shown that these exudates, lipoprotein exudates, starts from the intraretinal and through the outer retinal ellipsoid zone defects, it comes into the subretinal fluid. So these are precursor lesions and has been shown to immediate treatment with anti-VEGF or even better steroids. That prevents the poor prognostic hard exudate clump under the macula.
Okay. Thank you, Dr. George. You kind of summarized it well. Dr. Abhishek did touch upon it initially. So the size is important, and then you look at backscattering. That is also an important thing. Hard exudates do backscatter. Here, you do not have backscattering, and obviously looking at it clinically, you don't see them clinically. Hyperreflective foci, whereas hard exudates, you would see them clinically. Okay. Then we talked about different biomarkers in diabetic macular edema. The question is. Now, when do you decide to use, do you use all these biomarkers every time you see a patient with diabetic macular edema, or like you start them on some kind of therapy and then you decide to look at them a little later on, or like how do you go about looking at it? Can I ask Dr. Abhishek?
Yeah, so when the initial assessment of a treatment-naive diabetic macular edema comes, yes, of course, we do look at the biomarkers, especially to prognosticate to the patient. I don't think my initial treatment would, the choice of treatment would depend too much on the biomarkers, but definitely prognostication would depend upon the presence of certain biomarkers. And especially among that, I would consider drill and the external retinal architecture to be the most important.
Okay. Yeah. I think this we have got a warning. I think it's time to end our session. I'd like to thank each one of you for for spending this Sunday morning with us in this session. It was a great learning experience. I'm sure the delegates have found it useful. I think we'll end the session here. Thank you.
Right. Thank you so much, Dr. Manoj. Thank you so much,
everybody. Thank you.
Thank you, everyone. Thank you for this brilliant session.
Very well thought of. I think Dr. Manoj and Dr. Unni deserve all the credit. Thank you so much.
Thank you, sir. Thank you for joining us.
Bye. Bye, Dr. George. Bye, Abhishek.